Thank you very much, and good afternoon, everyone. I'm Padraig Dixon. I'm from the Health Economics team in the primary care group here at Oxford. So we're the bitter rivals of HERC, but I'm very grateful to have this opportunity to speak to you about this work. Excuse me. So this work is going to demonstrate a new method of undertaking long-term intervention cost effectiveness without using a Markov model, a similar type of cohort simulation. And hopefully would be a complement or adjunct to RCTs of interventions, but it's a way of efficiently doing, I hope, efficiently doing research and efficiently assessing intervention long-term cost effectiveness. And the particular application I'll be talking about is in relation to cancer. And there's three contextual challenges in cancer that make this, I think, particularly valuable. So the first point is cancer drugs have been getting very much more expensive over time in absolute terms and relative to median household income, as demonstrated on this graph in the US. A small part of this increase is due to cancer drugs getting better, so this partly reflects the entry of biologic therapies in the last generation or so, but it's largely independent of quality. The other thing, which is also the case with the development of many other novel drug therapies, is how long it takes to get drugs to the market. So you start with basic research, and if you're very lucky, 20 years later, you might have a marketable proposition to help cancer patients. But of course, there's a huge number of failed projects. It's very complex. It's very risky. And this alone isn't an explanation for why prices have been increasing, but it is part of the story. So making drug development more efficient would be helpful. The other challenge, which is true of every area of health economics, is to make claims about the value of the therapy. We need to have information on healthcare costs and some measure of effectiveness, which ideally would be something like QALYs. So we don't necessarily have trial evidence. We don't necessarily have good evidence from cohort studies. So we're stuck with observational evidence. And classic challenge here is to estimate the association between cancer status. So that would be the beta X parameter. This association will be confounded by all of these omitted variables that we know are also associated independently with cancer status, which is the exposure we're interested in, and, for example, healthcare cost as an outcome measure. So if the true relationship is that healthcare costs are a function of cancer and lots of other things, but we naively estimate that association because we don't have knowledge of these other factors that are confounding endogenous variables, then we end up with this biased association. And the extent of that bias will depend on how much covariance there is between these other factors and our exposure variable. So the solution I'm going to talk about here is solving all of those three problems in one fell swoop. And it's using common genetic variation as a way of segregating the population into people who have higher and lower risk of a particular exposure, which is cancer in this example. So at conception, we inherit our genetic makeup from our parents, 50% from father, 50% from the mother, give or take. It all gets mixed up. By chance, conditional on parental genotype, so it's truly random, conditional on the genes our parents have. Some of us will be at higher risk for particular exposures like cancer, like anything you can think of. And by this random process, some people will have lower risk. So that's very analogous to a randomized controlled trial where some people are allocated independently of any particular characteristics they have to have higher or lower risk of receiving a particular treatment. In this case, the treatment is an exposure to a disease. And in principle, subject to some assumptions, confounding factors will be balanced between these two different groups, and therefore we can make causal claims purely by looking at the genetic allocation that happens at conception, so 9 months before we're born, and then we can do a comparison of outcomes. So in this project, the first step we did was to use Mendelian randomization, which is what this process is called, and that's Mendel on the right, Andy Warhol style. We looked at genetic variants that are associated with druggable targets, so bits of the genome for which there exist drugs that do exactly the same as what the genetic variation does, and then checked if people taking those drugs, if people who had that type of genetic variation happen to have higher or lower risk of disease for indications other than that for which the drug is given. So this will hopefully be a little bit clearer as I demonstrate the example. Then you can do Mendelian randomization to assess the causal effect of cancer exposures on health economic outcomes. And then you hopefully have robust causal evidence on the association between exposure and outcome, which is very difficult to find usually. And then you can combine those two previous steps as a new way of doing long-term intervention cost effectiveness analysis. So the specific application we're looking at is prostate cancer as the exposure, and we noticed in this large project that people who have genetic variation randomly assigned at birth, which corresponds to an anti-diabetic drug called SGLT2, so sodium glucose cotransporter inhibitors. Those people have lower risk of prostate cancer, and that's a druggable target. So hypothetically, if you gave people who don't have diabetes this diabetes drug, they might have lower risk of prostate cancer. And we demonstrated this using some genetic data. We also made sure that this genetic effect wasn't purely because when you take this drug, you have lower blood sugar, lower glycated hemoglobin. We also demonstrated that. So this mechanism is happening independently of blood sugar. Then we attempted to triangulate that evidence using target trial emulation in electronic care records. So there we compared people taking these drugs, SGLT2 inhibitors, with people taking a different type of anti-diabetic medication and assess what their prostate cancer risk was. So the logic here is that you can find genetic proxies for drug effects. You can do this thought experiment where you're giving that drug for diabetes to people who don't have diabetes, because diabetic patients who happen to take this drug happen to have much lower risk of prostate cancer. And you want to see if that's causal. So we did those two types of analysis, the Mendelian randomization and the target trial emulation in electronic care records. And it turns out they give consistent findings in relation to the risk of prostate cancer. So the main genetic analysis, the odds of prostate cancer reduced by 71% in people with this form of genetic variation that's mimicked by the drug. 49% in replication analysis, so there's a little bit of a winner's curse or inflation of effect analysis, but still a really, really big reduction in risk. And also a reduction in risk in the target trial emulation using electronic care records. So there's something going on. We need to think about cost effectiveness modeling as well here. So it's not, as we know, it's not enough just to say we found something that might be beneficial. So we combine those two previous steps. So the finding that these drugs might be really effective at reducing the risk of prostate cancer, and the effect size from those different forms of analysis. And then we estimated these three quantities. How many men would avoid having prostate cancer? How many men would have developed it anyway? And then the impact of this cancer exposure using Mendelian randomization on healthcare costs and quality adjusted life years. And that's all you need to do cost effectiveness analysis. And then we did a simulation where we combined all of these different factors together. So if you do conventional multivariable analysis and naively relating cancer exposure to these two economic outcomes, prostate cancer does increase healthcare costs, it does reduce QALYs, and you get the same the same direction of findings with the Mendelian randomization analysis, but with much more uncertainty because the confidence intervals are a function of how much variation is explained in the phenotype by the instruments, and that's always much more uncertain. But either way, there's a big effect of having prostate cancer. However, because for most men, prostate cancer doesn't, it's obviously very serious for a lot of men, but at a population level, if you put this in the drinking water, which is essentially the situation in models, and every man takes 300 mils of this particular SGLT2 inhibitor, it wouldn't be cost effective because men don't get admitted to the hospital very often with prostate cancer, have very long, expensive stays, have huge reductions in quality of life. It wouldn't be cost effective unless the drug was very, very cheap. If it was as cheap as the cheapest statin, so about £30 per year, it would be cost effective, but not at any realistic price. So what have we found? So we attempted to do some triangulation. We get consistent evidence from these two forms of analysis, which have orthogonal assumptions, so the types of bias should be different. So the genetic evidence says these drugs reduce the risk of prostate cancer. The electronic care record also says the same. So there's potentially a strong case for doing an RCT of these inhibitors. Cost effectiveness is less positive, but we don't actually know what price this drug will be offered at for a novel indication. So that's a slightly negative conclusion to what was initially a really exciting discovery, that we found something that could reduce the risk of incident prostate cancer. But it does demonstrate the method, and it does demonstrate that you could very rapidly do this type of analysis before you spend a fortune doing a trial. So in the UK, there's plans to do the Transform trial. It's going to cost £42 million to control prostate cancer. It's very expensive. Maybe there's a case for having an arm where you have SGLT2 inhibitors, and we provided some of that evidence. And just to wrap up, thank you my co-authors and Cancer Research UK for funding, and the papers are now published if you care to take a look. Thank you.